which probably kind of mirrors how foggy and misty it is outside today anyway. So it's kind of a appropriate picture to have up there. And then sorry, Eric, do I press this mouse here to change the slide?
Can anyone else online see the slides? I can't.
Oh, okay. Online can't see the slides.
I can't, but it could just be me.
I can see the picture of the Auckland.
Yeah, very pixelated. Misty.
Oh, that's better. It's become.
She's got it. Eric,
she's got
it. Perfect. Thank you.
No, that's brilliant. Yeah. Okay, perfect. Thank you. Well, sorry for the interruption. So I grew up here in Tamaki Makaurau. I then went to this school here in Ponsonby, where I decided I was going to be an accountant. So I left school and joined the accounts department at this company, where, when I was working for them for 5 years, I decided not to be an accountant. So I transferred to this place, to Sydney, where I moved into the booking office, travel/sales side of Air New Zealand, and where I wore this uniform. It's actually not me in any of the pictures, but this is the uniform that we wore. I remember one weekend I was going to a party and I thought I'll dye my hair black, and I'd already had a dye in it. It actually turned green, so my hair matched my uniform. So just a bit of trivia about some of my, things I got up to. And yeah, so I wore this uniform while using staff travel, which was pretty much free, to see the world. So then I decided that using staff travel and confining that to annual leave and standby travel didn't allow enough time for travelling. So I then moved to Salisbury in the UK, and I lived with my auntie, who was a retired registered nurse. And based on another experience I had many, many years before then, visiting my auntie when she was a patient in hospital, I was in awe at the confidence and the way in which the nurses moved around my auntie. And so that was my first sort of, wow, this is pretty amazing. And then when I lived with my retired registered nurse auntie in Salisbury, it was there I decided to come back to New Zealand and do my nurse training, where I studied here for 3 years and became a registered nurse in my maiden name. And then I ended up working here. And along the way, I changed titles after completing the Doctor of Health Science.
Lovely.
So a little bit about my background. Okay, so my doctoral research topic was primary health nurses' experiences when working with children whom they suspect are being abused or neglected. How I came to child protection research. So my first encounter was with suspected child abuse, was when a 6-month-old baby girl was admitted to hospital with suspected sexual abuse. I was a student nurse at the time, and it blew my mind that that could occur to a baby. When I had my very own, very sporty children, I had various conversations with one of the sporting leaders of the organisation that one of my children competed within. And he was concerned about the behaviour of a coach towards athletes. So I ended up facilitating the development of a child protection policy for that regional sporting organisation, which then morphed into being asked to do child protection policies for local, other regional and a national or sporting organisation, all kind of sports related to what my children were involved in. I also had experiences as a registered nurse where I had suspicions about the safety of children. And I've also worked with student nurses in my capacity here at AUT where concerns about children's safety have arisen. However, in all the media reports that I've ever read, those ones that get to the media, I've always wondered, where was the registered nurse? I never saw them in the media reports about their involvement, about where they were. So I always wondered if they'd actually worked or had any involvement with that child at some point. So I sort of came to realise that there's very little known about the depth and breadth of work that registered nurses do. And as a profession, some really great authors, Baresh and Gordon, they feel that nursing is actually less than effective in communicating their work to the public. So really there were very few nurses telling their stories. And essentially, I felt that they were unseen amidst the silence, which made me want to better understand their experiences and their stories. So the focus is on, sorry, I'll just go back here. Nurses have concerns that stay with them until that concern is either confirmed or refuted. However, sometimes they are never resolved and they never know. And that concern stays with them, that suspicion stays with them over time. Just a little bit about my doctoral research. I used a qualitative methodology using Gadamer's hermeneutics, used to guide how the study was conducted. And hermeneutics is an interpretive approach whereby interpretation of the data by the researcher is used to create new understandings about the phenomena being researched. So I was privileged to have 13 primary healthcare nurses share their experiences in one-on-one semi-structured interviews with me. Okay, so why is this important? So this is really important for a number of reasons. Nurses' critical role is identifying, working with prevention and responding to concerns around child safety. It's a critical part of all nurses' roles, but of course this research focused on primary healthcare nurses who work with healthcare service users in the places where they live and conduct their daily lives. There's very little about primary healthcare nurses' experiences in this area in Aotearoa, New Zealand more so. There was a dissertation done in 2010 by a Plunkett nurse focusing on Plunkett nurses, and there was another master's dissertation conducted in a SCABU setting, but not using a broad range of primary healthcare nurses across a range of settings. And I also wanted to ensure that nurses' voices were involved in policy development and sharing what their stories are like, and in education and in practice. However, this is the real reason why this is really important. These are actually some of the many children who have died in Aotearoa, New Zealand because of child abuse. And we know that Māori and Pacific children are overrepresented amongst this group of children. And so we know from other data that Aotearoa, New Zealand ranks poorly amongst OECD countries for both child abuse and child homicide. And something really has to change. And, there's a lot of people in this room who are working in roles to make that change, which I applaud you all. The first theme in my doctoral findings was about building and nurturing relationships. So this was the first of three themes. So what I'm going to do with each three themes, I'm going to illustrate each theme with data extracts and talk to you a little bit about that, what was behind that experience for the nurse. So what I want you to do is just imagine for a moment that you're a nurse working in the community. You're meeting with a family for the first time after having received a referral about a child. After reading the referral notes and case file, you're alerted to the possibility that something may not be quite right. You wonder about the risks for the child, but you worry that you might be wrong. So you try and keep an open mind. Going into an unknown environment, you do not know how you will be received or if you will be received. According to the Health and Disability Commissioner, the family has the right to decline health services and can therefore refuse to see a nurse. So as the nurse, you know you need to build a relationship and you need to nurture that relationship with the child and their family. So primary healthcare nurses who work with children who may be at risk of abuse know that these relationships are critical. They are the priority for them. And what matters most to the nurse is actually getting to know that child and the family with whom they need to work with. And that's essential if they're not only to observe what's happening, but to offer help and support. So every child is uniquely situated, often in pretty dynamic and uncertain circumstances, which really makes that nurse-client relationship really important. So establishing that relationship is critical for the nurse. So primary health nurses work pretty hard to establish relationships with children and their families, always with the intention of building rapport and, of course, gaining trust. The relationships they build across a range of settings, such as GP clinics, nurse-led clinics. They might be in people's homes and in schools and a variety of other settings. So nurses generally work alongside children and their families or their guardians and liaise with other people, such as teachers, social workers, doctors, other nursing colleagues, and their own managers. So there are times when these relationships can occur relatively easily, but there are other times when it's actually more complex, it's challenging, and it can be quite uncertain. So that requires perseverance from the nurse, which is essential for them to be able to adequately assess what is happening with a child and their family in any given situation. So because primary healthcare nurses often deliver health services in people's homes, they're essentially arriving into someone's home as a guest. And therefore, one of the cornerstones of nurse visitations is really critically developing that relationship and nurturing that relationship with the family. Because these relationships are critical for the nurse to be able to connect with the family and help and support them. So this is one of the first data extracts in this theme. This is Tanya, who said so much work goes into setting up relationships with families. When you're engaging with families at any level, you have to do a lot of listening and a lot of setting up that relationship, and it's based on trust. So Tanya was a very experienced primary healthcare nurse. She works hard to build relationships and trust and understands the importance of trust when trying to build these relationships with families. But trust is one of those intangible assets in nursing, and it doesn't automatically occur. It may be sometimes that the nurse has automatic trust. However, sometimes in more challenging situations, this has to be consciously worked on by the nurse to develop trust to then establish a relationship. Often when a nurse wants to observe an environment because they have suspicion, even before they visit the family, they want to assess the risks to children. So to be let in to that relationship, let alone the physical bounds of an actual home, they have to establish trust. So Tanya's experiences have taught her that establishing trust are both interrelated and interdependent. However, she knows that she can't build trust without a lot of listening, but she needs some degree of trust for the family to actually let her in, to allow her to then do that lot of listening with them. So placing trust in someone else, i.e. when a family places trust in a nurse, can actually make people feel quite vulnerable, particularly when they're in their own home. And it can come with an expectation that the person who is trusted, i.e. the nurse, will maintain the dignity of the person that is granting that trust. Families can often feel quite vulnerable when someone is observing them in their own home, or at a time when they're needing assistance or healthcare from the nurse or anybody. Therefore, in nursing, listening is to also understand the power imbalance and the vulnerability of families. Another data extract from Araha, who was a whānau ora nurse. She says that working in a Māori organisation, we work on building that therapeutic relationship and trust right from the beginning. I've learned over time and use the pauwhiri process. It starts when I'm welcomed into a home and go from tapu to sharing a bit about each other, where it then goes to noa, or normalised. I use my life experiences and share something we have in common and try to make a connection with them so that they start to feel more relaxed. I try not to be overpowering, as nurses can sometimes be seen as overpowering, and I'm not going to tell them what to do or how they're going to do it. I work alongside them. The relationship builds from there. It's a skill I've learned over time, and you have to have that time to develop the relationship. In the community, we have that time. So Araha draws on her personal knowledge of Māori cultural practices and takes time when trying to build relationships with whānau Māori. Most of the families that she worked with were whānau Māori, which is the purpose of the whānau ora organisation that she worked with. We know that Māori culture values whānau rather than the individual. Therefore, one of the important cultural values is the collective nature of health and well-being of whānau, rather than simply trying to address the individual itself. So Araha draws on her past nursing experiences and cultural knowledge to help build and nurture relationships with whānau Māori, and acknowledges the traditional importance of entering every new space with every new family. She knows that flaunting her knowledge and being in a way that will be overpowering will not help build trust. So she knows that this will lead to a power imbalance. So she considers that with every interaction. But Araha knows that she must continue to develop the relationship if she is to avoid the risk of being turned away. This is another data extract from Debbie. Holes in the wall. That's a huge indicator of violence. I would always ask families how this hole came about. So I would go around the house and I would ask, how did this hole and that hole happen? When I'd explain, I'd say, oh, that's interesting, or that's unusual. People would either talk or not. Once I went to a house and counted 16 holes around the double bed. There was no other explanation apart from family violence. So I ended up sitting down and I said to her, was the mother, it feels like there's a lot happening in the bedroom. Is that to protect the children? And she said yes. She said yes because I didn't ask her if it was violence. I just asked about protecting the children. That conversation formed a connection with us. So while Debbie was immediately concerned and suspected domestic violence, she is careful not to show it and rather focuses on the aspect of protecting the children. So the priority for her is to start building a relationship and developing rapport in order to gain the mum's trust. Acknowledging the mum's need to protect her children is actually a really significant way of building trust. This encounter led Debbie to suspect that the mum was protecting her children by limiting the violence to the bedroom, where the children would therefore be less exposed to it. Debbie asked questions in a way where they could basically go any way where the mother wished them to go. So left that quite open for her. And she really used humility and open-mindedness in her conversation with the mum. Her responsibility with the mum, or within that responsibility, she also used frankness as well as open-mindedness as a means to develop trust by asking the woman direct questions, which was particularly skillful because it navigated around the aspect of violence and looked at just protecting the children. So acknowledging the woman's need to protect her children is a significant way of building trust, particularly in light of a quote from Gere, Cozy on McLean and Epple back in 2010, which quoted that uncertainty often manifested as doubt of what to do when a primary care professional encountered somebody impacted by domestic violence. So I thought this interaction was a particularly skillful way of navigating that uncertainty, navigating that way of building trust with somebody and using a variety of different questionings there were other questions that she used as well, to really sort of develop that relationship and allow the woman to open up if she wished to. Okay, this is another data extract from Debbie, where she was trying to be useful to build trust and a relationship. So she said, so this is a grandma who didn't answer the front door the first time I knocked. So I went round the back and she spoke to me through the laundry window. In order to talk to somebody from the laundry in a state house, you had to physically lean over the tub. So there was a high level of suspicion. That was suspicion from the grandma. After about 3 to 4 visits, talking to me through the window, I realised that unless I was useful, my relationship with her wouldn't work. I needed to prove I was useful and reliable quickly. On the 4th visit, she said to come around the front, which I knew was a big step. So I went around the front and into the house. It was extremely clean and extremely stark. There was almost no furniture. We sat down and talked about a lot of issues, and we formed an extremely close relationship. So this was when Debbie was trying to talk to the grandma, who was the guardian for a 5-year-old boy called Wiremu, who had some concerns that were risen by his teachers at school. And so Debbie was trying to build that relationship with the grandma in order to talk to her about what was happening with Wiremu and address the safety concerns that the teachers were concerned about. So this was one that Debbie particularly remembered because of the way in which the relationship was needed to develop. So Debbie knew that trust was critical in order to build this relationship, but it was clear that the grandmother's early suspicion revealed a very big lack of trust towards Debbie. So Debbie persisted with the home visits, even though she had to initially conduct them from outside the laundry window. But as a Pākehā nurse, Debbie accepted the suspicion towards her from this Māori grandmother and made sure that she didn't impose herself upon that relationship or the grandmother and didn't rush that building of trust. So typically when nurses visit children or their families in home, they tend to read people to establish whether the person is ready and for ongoing contact. And if a first visit doesn't go to plan, they often go back and do repeat visits. So this is exactly what Debbie was able to do. She had to prove that she was useful in order to be able to talk to the grandmother and be able to be let into that relationship, let alone the physical home, in order to try and help address the issues that Wiremu was facing that the grandmother may or may not have been aware of. So Debbie also faced uncertainty as to whether she would be able to build trust with the grandmother, but was pretty patient and let the grandmother reveal when she was ready to start trusting Debbie. So Debbie's perseverance and her responsibility to build ethical relations led to her being able to help Wiremu and keep him safe with issues that the teachers raised at school. So building relationships interprofessionally is also critical for nurses to work with children and families that they are concerned about. So this was Emma, where she did a home visit. And she says, there were random people in the home when I would visit and smoking inside the house. I'm using the word SIPs because that was the term that was used when I collected data. So we just know we need to translate that to oranga tamariki, but I respect the terminology that the nurses used in their data. So a SIPs social worker investigated the mother and concluded everything was okay. I didn't agree with this outcome. I knew the mother wasn't telling the truth to the SIPs social worker. As a nurse, I know families tell you things they won't tell a social worker because families fear the social worker will take their child away. I guess nurses come from a different angle. Even though families know I have to report my concerns to SIPs, they know we as nurses are not going to take their child away. So what happened with this situation is Emma was visiting a young pregnant mother where concerns about the risks to the unborn baby arose. And they arose because the mother had diabetes, but disclosed to Emma that she doesn't monitor her blood sugars, that she couldn't remember the last time she took insulin, and had not been attending any appointments. So Emma was concerned that the mother was placing the unborn baby at risk by not managing her diabetes, but she also had other concerns about other activities that were happening in the home. So she reported these concerns to the SIPs social worker, and of course we know from Emma's account that the social worker believed the mother's account over that of Emma's. So while Emma appears to have a relationship and trust with the mother, the relationship and the trust with the social worker is also needs to be developed and nurtured. That the social worker has responded to Emma's referral and actually visited the mother and her home suggests that the relationship and trust is developing between Emma and the social worker. But perhaps if Emma had more time to build and nurture the relationship with the social worker further, the social worker may have trusted Emma's account against that of the mother's. However, according to Emma, the social worker had the same access to the systems that showed when prescriptions are being used and redeemed and when appointments are missed and rescheduled. And with some nurses, missed appointments can be a trigger to wonder if there are concerns happening in a family. It doesn't mean that it is, but some nurses red flag that as a potential concern. Okay, so this is very text-heavy slide, so I'll just read this to you. So this was Karen's account. Mum had mental health, gambling and drug issues and was at a casino gambling. She had 3 adult mental health agencies going to see her, but no one had picked up on these kids. In the house, when Karen visited, there was a sofa that had bits picked out and torn apart. There was nothing in the fridge, and I mean nothing, and it was grimy and festering. The bedroom was Spartan bare, with a bed and cover, but no sheets, and the mattress was stained. So it was basic, basic, basic. It was a nice house on the outside, but the inside was derelict. It was derelict. It was awful. There were teenagers sleeping all over the house with another school kid there. During the visit, I had to be careful not to show my shock to the 2 girls as they loved their mum. I had to say that it wasn't okay, there's no food, and that I needed to talk to mum as they needed to be at school. I talked to the other agencies working with the family, and we all did a referral to SIPS, because if I did the referral alone, SIPS would visit and the mum would deny being at the casino. SIPS didn't really pick up on it because with neglect and emotional neglect, it's always really hard to deal with the emotional stuff. People don't really pick up and react to the emotional abuse easily, which is probably because there's nothing physical to see. But I think it does far more damaging long term. SIPS had already been to the house because there was a fire in the garage where an older sister was living with her baby. So SIPS removed the baby but left the 14 and 9-year-olds. Mum would have had good intentions and really loved her kids, but when she got into gambling and drugging, she was just lost and wasn't present. The 14 and 19-year-olds got removed from the house and were made to live with their auntie. So after Karen's visit, she had to rely on the relationships and trust that she'd developed with other agencies in the first instance to keep the children safe. She knows the mum loves her children, but has other issues that prevent her from providing the necessary care. However, she's yet to build a relationship effective enough for the social worker to trust Karen's account against that of the mother. Without testing that trust with the social worker, she went straight to the other agencies with whom she already felt she had built a sufficient relationship with and was confident that she had their trust. So such relationships for Karen were the means to achieve the ends of having the social worker involved. So a consequence of not having built a sufficient relationship with a social worker is that Karen's assessment of neglect could be overlooked and the children could therefore remain in an environment that was unsafe. However, even without a relationship, the trust of the social worker, Karen had developed other ways for helping children that she felt were at risk. And then we move on to theme 2, which was called Being with Suspicion. So to be with suspicion in this study is to have that really uneasy feeling that something is not quite right. It was a concern and a feeling that compelled the nurse to look for other cues. It often led to a very deep watchfulness that ended up heightening what the nurse would notice. And it often began with a gut feeling and that instinctive feeling that just something is just quite wrong. So this feeling of being with suspicion, this feeling of suspicion is particularly relentless for the nurses in the study. It was always present. The nurses developed a deeper suspicion that the risks for a child existed in their view, and it was when they sensed something was wrong within that suspicion that compelled them to keep looking and look for other clues to either confirm or refute their suspicion. However, sometimes their concern or their suspicion was actually never confirmed or refuted, and that sense of suspicion remained with the nurses forever. And even doing these interviews with the nurses, every nurse in the study, you could feel the palpable emotion that they re-experienced when they were retelling these stories. So it's very strong and it's relentless and ever present and stays with them for a long time. So experiencing a gut feeling. The next data extract is by Tanya. She was visiting a 13-year-old child in the family home where the 13-year-old lived with the grandfather, with 13-year-old's older brother and his wife. The 13-year-old had just had a baby, and so Tanya was going to do the home visit to do the well baby check and a check for the 13-year-old as well. Something about the grandfather gave me a really awful feeling. There was something about the way the grandfather responded to women. There was the sense of power the grandfather had in the house. We thought it was a hierarchy in the family. Quite a lot later, the 13-year-old girl disclosed it was the grandfather who sexually abused her and was the father of the child that she had just had. It was a sordid situation where the grandfather would sit in his rocking chair and in the presence of myself and the SIPS people would ask the girl to tell us who the father was. It was really sad because he had also abused the brother's wife who lived with them. Neither of these two females knew the other was being abused. The older female kept a secret because she knew it would blow the family apart. So working with children whom nurses suspect of being abused begins with that gut feeling that something is just not quite right. And our feelings signal to us what matters before we often have the words to express them. This really awful feeling that Tanya describes signals something visceral and something really significant in terms of the messages that are sent within our body. And the messages between the gut viscera and the brain often happen without conscious awareness. They happen, or they're based on signals moving between both the gut and the brain and evoke that emotional response and that feeling that we have that something's not quite right. One philosopher called Van Manen used the notion of lived body to describe how our bodies reveal things that matter. And therefore this gut feeling, really does reveal what matters to the nurse. The grandfather's sense of power was physically palpable to Tanya, and in the absence of proof, she wondered how and why he held this power. So it was through noticing subtle cues that nurses, such as Tanya in this situation, stay alert and vigilant. She sensed that something was not right within the family dynamic. She understood that the interpersonal tension she felt was a concern, but only learnt the full story sometime later. Experiences that signal a gut feeling. This was another home visit by Natalie, which I'll reveal the data extract soon, where the nurse also was concerned somewhat about their safety for themselves. The mum was usually quite chatty. On one visit, she wasn't. At first, I thought she was in a rush, but then I began to feel like there was somebody else in the house. The mum's partner was not allowed at the house because he had physically abused the baby. When my colleague did a visit unannounced, he answered the door. I suspect he was hiding in the house when I visited. So during this home visit, Natalie experienced that gut feeling that something was different. Something told her that there was concern in the way, and the subtle nuances in the way the mother was behaving. So we use intuition in nursing, and Benner and Tanner call intuition understanding without a rationale. So nurses rely on what they notice to inform their intuition in order to try and make sense of the situations that they're in, which is exactly what Natalie was trying to do. So noticing subtle cues from a home visit, it helps support nurses' suspicions before they're able to form a rationale as to what is informing that suspicion. And often that suspicion is felt even before it becomes a conscious thought and the words come to mind to be able to describe what that actually means. So when suspicion compels action. So this is Karen. One time I went to do a 6-week baby check, the first visit. I put the baby on the floor to examine and dress the baby, and as I'm kneeling down, I see a sawn-off shotgun under the sofa. Oh! So I did my bit, and afterwards put in an incident form and talked to social services and police. The police told me they don't visit that house alone. They only go in twos. Yet Karen was alone. Nurses can be thrust into situations without any warning, where not only they have a concern about the safety to a child, but they have a concern about their own safety as well. Karen's trust in both her and the baby's safety was immediately shattered upon seeing the firearm. So her first instinct was to want to leave the house as soon as possible. However, despite the overwhelming and immediate risk and suspicion for herself and the baby, she had to wait. Before she could leave, she needed to remain watchful for any other cues that signalled further risk, but she also needed to conceal her shock and her outward awareness of the risk that the occupant, that the dad, may pose to both herself and the child. The relentless nature of suspicion. So this is another extract from Karen. There are so many red flags around child abuse. They, the children and youth, are just screaming out for help. If you ask the right questions, you know they'll answer, but you need to support the conversation so you don't just go in and ask about anyone touching or hurting them in a way they don't like. It's about leading up to this, starting with, so who's at home? Who do you feel safe with? Home can be a really hard place, but mostly the children are happy to talk about home. It's not prompting them, it's using open-ended questions so they have to answer. Because if you use closed questions, you'll only get a yes or no, and that leads you nowhere. When these kids came to see me at the intermediate school I was working with, probably every month I would get a disclosure of sexual abuse. So she negotiated with an intermediate school to have a clinic 1 day a week. So a month would usually equate to about 4 days. So for Karen to know that children are screaming out for help is to understand that they need the opportunity and the safe space to disclose abuse. Karen's questions enabled any red flags that might arise to be revealed. But to be ready with these questions is to carry suspicion into every encounter. So while a suspicion may cause the nurse to make a referral to another agency, a disclosure provides proof that better enables the children to be protected from further harm. So being with suspicion compels Karen to do all she can to protect children from ongoing abuse. I remember her telling me that she had to work for quite some months to negotiate with the intermediate school to hold a nurse clinic 1 day a week. So she was really thrilled when she was able to actually be let in with that relationship that she developed with the school to actually hold this clinic. So there was a lot of build-up to her being able to run that clinic 1 day a week. So whether nurses realise it or not, suspicion is always present during home visits, and it's relentless, it's inescapable, and sometimes it's all-encompassing. And then we come to the third theme, which was carrying the burden of concern. So nurses know that there are significant consequences for children that do experience child abuse and neglect. That feeling of suspicion feels like a weight for the nurse, but it's the knowledge of the consequences that contribute to that feeling and that weight and the burden that they carry. But they often carry the burden alone, and they often carry it unsupported. Nurses experience emotional, physical, and legal burdens. It's not just an emotional burden, and they often described it in the study as feeling heavy and very stressful. Yet these nurses in the study did not waver in their work that they wanted to do to protect children. So carrying the burden of concern, carrying this alone. So nurses often see missed appointments as a health issue because from a health perspective, it can be a precursor to poorer health outcomes if you don't get your child immunised. But it's also a precursor that someone in the house is not taking responsibility. A family may decline an appointment, which is different from not just showing up, but they're chaotic that they forget. So it's the chaos that's in the household When the nurses let SIPs know about missed appointments, they often won't activate a case until they have 3 hits. And that's where SIPs is contacted 3 times about concern for a child. At which stage they'll do something. So nurses hold on to that concern for a lot longer than anyone else and carry that. I don't think there's an environment of partnership. So not only do nurses visit families on their own, but they can also feel unsupported despite the presence of other agencies such as Oranga Tamariki and other agencies that may be working with these families. When children miss health appointments, such as with immunisations, they're often rescheduled and new appointments are sent to the parents. But this cycle can go on for often up to 12 months. Where, depending on the health service, at 12 months of missed appointments, they then might discharge the child or the family from the box, and therefore there'll be no further contact. Although missed appointments may not on the surface mean that a child is at risk, it does raise a concern for Karen that compels her to want to find out more. Primary healthcare nurses usually see families over period of time, and therefore they're really well placed to know when and why visits are declined, or more importantly, missed altogether over a short or a longer period of time. So Karen's understanding of the implication of missed visits come from her experiences, having worked with families and having observed negative outcomes with children over the course of her career. Karen is a nurse practitioner and has significant experience over her nursing career working with children, youth and adolescents. But for Karen, it's the call to care that gives her that sense of responsibility for the children and the families, so that she keeps a note of missed appointments when it's rescheduled and when she needs to draw on other agencies to support the family. She knows that even one hit may mean increased risk for the child, even though she doesn't make the assumption that that is the case. But waiting for 3 hits contributes further to the emotional burden that she carries. And it's that nurse's sense of responsibility that helps sustain their call to care amidst the heavy emotional burden that they carry over the course of time. So carrying the burden of concern, the nature of the burden. Megan said, it's stressful work. I did find I got very stressed sometimes. Some cases I was just so pleased to see the back of because they were just so complex. There are a lot of cool families out there who are really grateful for all your help. Actually, probably 90% of them are really good. Not easy, but pretty straightforward. I really struggled with the complex cases. I didn't trust my own ability around risk assessment and felt very stressed and used to fear I was going to be held accountable for something going wrong. I was always thinking, what if this is the case that ended up in court? Have I got good rationales for what I did? So the burden of working with families with complex needs also has inherent legal implications for nurses as well. And Megan is really describing the stresses and fears she experiences. However, she's worried about the vulnerable children who she works with and is fearful of being held accountable for anything that she may miss and anything that she may not do that may further put children at risk. And then the children end up being that cases in the media and in the courts. So getting something wrong doesn't only have adverse outcomes for the children, it may also mean for nurses having to defend yourself in court. The nature of the burden that Megan implies is that she's always thinking about this as a possibility. And so it sits on her shoulders as a load, almost as if she is waiting for something to go wrong. So feeling inadequate, Megan doubts her own ability around risk assessment. And although she describes 90% of the families she works with as not easy, but pretty straightforward, it's those 10% of the cases which are complex that increase her fear and stress. So it's the smaller percentage of the cases that she encounters with their complexity that adds to the weight of the burden that Megan carries. Many of the jobs that nurses do, nurses are exposed to, create extraordinary levels of stress. And that's reasonably well documented in the literature. but it's often exacerbated when exposed and contenting with the suffering of others. Hence the burden that nurses carry when working with children whom they suspect may be experiencing abuse or neglect. So Megan does her initial risk assessments, but she does this alone in the home before going back to the office to seek guidance and advice from her colleagues when she's back in the office. So working in a stressful environment, particularly one where Megan sees the suffering of others, highlights the deeply felt impact for her, and therefore the fear and the emotions she experiences. So in Megan's case, what happened was the level of suffering resulted in her resignation after 12 months working in this role. She felt unsupported, and after the interview had concluded, she told me that she was never offered professional supervision or any other form of assistance other than the conversations with colleagues back at the office when she returned from her day of home visits. She also said that she never asked for professional supervision or any help, because she felt that having to do so exacerbated her feelings of inadequacy. So nurses carry a burden when working with vulnerable children in a number of different ways, not just directly related to the children, and it can be indirectly related to the children. Okay, so this is Karen's account of the burden that she carries and experiencing this as heavy. I asked one girl around 11 years old, this was during one of the school clinics, who else lived in her house? And she said she was living in a boarding house with mum and all these other men. You also ask how they're getting on at school. And she said she couldn't concentrate because she kept seeing rape things. She was having PTSD flashbacks and night terrors. She'd wake up and see red, blood and black and awful things. She'd been sexually abused living in that boarding house with her mum, who couldn't protect her. It turns out the mum had a bad history of trauma and sexual abuse herself. So the mum would send the daughter to stay out of town with family and was sexually abused when she was there by a family member, the same family member who sexually abused the mother. It's making me feel like, because this was a particularly nasty one. Karen felt the full weight of her emotions when retelling the story to me. Much, much later, she still feels that feeling of and that particularly nasty aspect of the story, and describes that bodily response to what are pretty ghastly details. It also reveals the conflicting emotions from deep empathy to for the child to deep abhorrence to the perpetrator. So understanding the seriousness of the girl's situation not only arises from what she sees and hears, which in itself is pretty powerful, but also from the way it makes her feel physically. According to Merleau-Ponty, our body is the vehicle of being in the world, and thus explains, with also Van Manen's bodily notion, how we embody the emotions we feel and experience them. So therefore, for Karen, the nature of the burden that she carries from this situation is one that feels heavy, both bodily and emotionally. And the burden of her concern, which she's carried from the time when she had that encounter with the child to even when she had the interview with me, describes how she felt when retelling the story. While suspecting child abuse is known to cause distress for nurses, one can only imagine Karen's distress upon hearing a disclosure such as this from a vulnerable child. It is recommended that nurses who work in schools need to be prepared to encounter child abuse, yet little can prepare one for the immediate physical sensation and the response in our body when we hear such disclosures. And that accumulative effect is likely to increase the burden that nurses carry. So Debbie said, my threshold of concern was much lower than the threshold of SIPs, so I would refer issues to SIPs if I was concerned. They may make a decision that no intervention was needed, but it didn't feel to me as if the issues were alleviated. I would manage this by putting my hand to my knee, and I would say that I carry the children of concern from here, and then I'd put my hand above my head, and the children above my head would be taken by SIPs. So the children who ended up in neurointensive care from head injuries would be taken by CITS. But the children with blood in their knickers where no one could prove they'd been sexually assaulted, I felt I carried that. I would meet weekly and just chat with children who had blood in their knickers because I thought if they developed a relationship with me and trusted me, they might tell me what was going on. So Debbie's way of indicating the burden that she carries is by physically placing her hand on her knee and indicating where she would intervene, and then raising her hand above her head to indicate and demonstrate the level of abuse of concern when CIPS would act. So that statement, I carried that, refers to her juggling those different thresholds of concern between her lower threshold of concern and CIP's higher threshold of concern. And it's that gap that she carried until CIPs were able to intervene. She is essentially the keeper of these concerns until CIP's threshold enables them to intervene. So she carries that burden of concern until that threshold is eventually met. So at the foundation of nursing is our duty to care, and therefore what comes with that is nurses' willingness to take on the pain of others, and that is a consequence of the call to care. But what we're acting on, what we see, we hear and touch results in consequences that not only form the purpose of nursing, but it also talks to us more about the pain of others. However, the inability to protect others or to even preserve life weighs heavily on those who are called to care, as such as the burden that nurses carry. Okay, so those were my 3 findings chapters, but what next? So at the moment, I'm doing the data analysis for a research project that I collected data from last year. So that research was about nurses' suspicion of child abuse, and it really looked at how the suspicion arises, how they respond, any barriers to responding, what solutions they see and how they can be part of that. But what I also looked at was any biases that inform that suspicion, which is really interesting because so far in the analysis, those biases are both personally and culturally situated. So that was really, really essential to add. The research involves both primary healthcare nurses and tertiary nurses, so it's looking across both settings. The research was conducted using focus group settings, both virtual focus groups and in-person focus groups, which enabled me to collect data from nurses from the very north of the country to the very south of the country. So, so I'm during the data analysis stage at the moment. And then, what then? What I would like to do next is, based on the analysis, the preliminary analysis I've done so far, is that there are 3 provisional barriers that nurses face, and one of them are systems, one of them are social work, and the other is education. And so what I'd really like to move on to next is some interprofessional research. So I formed an interprofessional advisory group of a variety of experts who work with children. And so at the moment, I'm just scoping out what that might look like, with the aim for next year applying for funding, possibly an HRC grant for that study. So that research question is yet to be refined. The data from this current project analysis will help shape what that project looks like as well. And I've got a research assistant who's doing a scoping review on interprofessional responses to child abuse. So I've also co-founded a new organisation called the Nurse and Midwife Child Protection Collective. I've got the link to the Facebook page, which is very new, so there's hardly anything on there yet. But you guys are actually the first to see our new logo. The background will be a little lighter, but that is our logo that will eventually, when the artist that's doing this voluntary work for us, when we've finished that will go on the Facebook page, but at the moment there's other illustrations on there. So, yeah. So, Ane Whatai, thank you so much for your time and listening.
Thank you. Just join me in thanking Susan for sharing this important work. Thank you, Susan. I think it just brings up so many issues.